Our vision is so important for maintaining our independence, but also for staying socially connected and doing the activities that we enjoy. Join us today to learn about advances in medicine and technology that can help you age well with good vision and maintain your independence. Hello and welcome to Aging Insights. I'm Kathy Rowe, Executive Director of New Jersey Advocates for Aging Well. And today we're in Montclair, New Jersey in the state-of-the-art offices of B&C Eye Care Group. We're here with Doctors Tanya Carter and Frank Barnes to learn about eye care as we change and as we age. Doctors Carter and Barnes, thank you so much for joining us. So can you start by telling us, how does our vision change as we age, and what's a normal part of aging and what's not a normal part of aging?
Well, the main thing that happens when you age is that you lose your focusing system. That's like the biggest thing. That's called presbyopia, and that's when you can't read. All of a sudden, words start getting smaller up close. You find yourself pushing things away, and there you go. So that's a normal part of aging. And then we would even say cataracts can be a normal part of aging because your metabolism changes, your body's breaking down. It's just how it is throughout top and bottom. Some very common things that happen though too, which I would throw in that normal part of aging, is floaters. So that's a big one. As you get older, oh, you see that spot, it moves when I move my eye around, what's going on? People get really concerned about that. But it's typically a normal part of aging, although we do still make sure that there's nothing going on in your retina when you get a floater. But for the most part, we walk away with, okay, it's just a normal part of aging. And I think the other thing would be changes in your lens and your retina. And when I say change in your lens, a cataract is when the lens gets cloudy. And then we call it a cataract when you lose vision. But the lens is still changing. For a simplified description, it's yellowing. So when that happens, that's going to affect your contrast. That's going to affect glare, cause glare. And that's going to just decrease the amount of light that gets into the back of the eye. And you just won't see as well at night in the dark.
A lot of older people stop driving at night because they don't see clearly, so that's related to those changes in the retina.
Those changes. Reaction time, that's a big one, why people stop driving. But definitely your night driving, your night vision definitely declines. Yeah.
So what can be done for night vision?
The first thing is the best vision possible. That's the goal. Got to get the best vision, the best pair of glasses. Then when you have glare, there are some things that can help with glare. There's anti-reflective coatings that you put on, but sometimes that doesn't quite do it. And you need maybe some extra tint that helps at night. So for example, there's a yellow tint. It's like an amber color tint that helps cut the glare out a bit. Yeah, so it's not a lot, but
sounds like something I should try.
Something you can, no, it's definitely a problem for people.
And then what is not a normal part of aging? When should people, call and make an appointment because something just isn't right and they're thinking, oh, I'm just getting old, I'm not going to worry about it?
I would say a sudden loss of vision. The thing about aging eyes that's normal is it's more gradual, right? You don't even notice half the time until then, oh, okay, I realize I'm struggling a bit. But if that's sudden loss of vision, that's a problem. It's seeing spots that aren't like moving floaters, but every time I look at you, there's a spot in my vision. That could be macular degeneration, or a curtain coming down. That could be a retinal detachment. So those are some basic issues that occur that can, let us know that, okay, something's going on more than. And even the floater, I would say it's not an ocular emergency, but if you have a floater, yes, you call up. We may not say come in today, depending on the situation, but it's certainly worth a call.
Okay.
Yeah.
So when we talk about geriatric eye care and eye care for older people, what is the focus of it compared to eye care when you're younger? What are you looking at as for your geriatric patients?
The focus would be the best glasses. The focus is ocular disease. So you've got things start happening when you get older. You got the big three, your glaucoma, no signs or symptoms.
Oh.
That's a big thing. You've got, and so that creeps up on you and that robs your sight, and it really does. Macular degeneration, you want to detect that early and make some interventions, because nowadays there's much more that can be done about macular degeneration, so catch that early. And so it's disease. If you have diabetes, definitely it's going to manifest. You can have diabetes, no retinopathy, where there's bleeding in the back of the eye. And then as you get older, the more years you've had diabetes, even if it's controlled, the more likely you are to have retinopathy.
Okay.
So yeah, I'm controlled, my sugar's good, my A1C is good. That still doesn't mean you won't get retinopathy. And again, there are more things that can be done intervention-wise nowadays. So catch that early.
You both have stories of how vision affects. It's more than just reading, and it's more than just it's more than just seeing. That our vision can impact other parts of our life, and I think you've had some experiences where helping someone with their vision benefits so many other aspects of their life. Can you share some of those stories with us without giving away patient information?
Yeah. So glare, or when you have a cataract, it distorts color.
Oh, really?
Yeah.
Okay.
Especially blues.
Okay.
Blues look like black sometimes, or you can't distinguish like navy from black, or different hues of blues. So one time I was in the diner, right? So I'm in the diner. It was a crowded diner, and this woman came over to me. Of all the people in the diner, she chose me to come up to and ask me, what am I matching?
Okay.
And sure enough, she had hues of blue on. So you can't quite tell, especially if the lighting is bad in your home. Is this blue? Is this black? I've got one blue sock and one black sock on. I've got, a blue pair of pants and a black shirt, or black pants and a blue shirt. You typically aren't doing that with navy, say. So, and she knew she was having problems, but yet could not really, wasn't sure exactly what it was, or she knew she struggled that morning getting dressed. So, so for me it was like, okay, she probably has a cataract. Yeah.
And she didn't know you were a doctor when she came up to you?
I didn't have a lab coat on. I was like, of all the people in this diner, she came to me. So anyway, so that was one story. So that's quality of life. I mean, she was a really sharp lady.
Yeah.
Dressed very nice. So that kind of stuff matters to her. So I have this woman who, she lived in the long-term care facility. I used to work in a long-term care facility and do eye exams. So I saw her a lot because she lived there. And she would come down to the eye clinic, and she only spoke Chinese.
Okay.
That's all she spoke. And finally, and she had a cataract, and finally we convinced her family members to allow her to get the cataract surgery, because she wasn't able to decide that on her own.
Okay.
So, and we used to have, when she would come to the clinic, we used to have the nurse who spoke Chinese come and assist us.
You need a translator.
We needed a translator. Years, I'm talking. So finally she got the cataract out, and then the post-op, so you get the cataract out, you have to follow up in the clinic the next day, in the week, whatever. She comes in and she spoke fluent English.
How,
Yeah.
how did that happen?
How did that happen? So although I have no, research behind it, but my perception is that when you're blurry, you revert back to most comfortable for you, and that would have been her language.
Okay.
Her first language.
Okay.
So she can't see. It's like almost like you come full cycle, in your development.
Right.
And so then you get the cataract out. Now my world opens up.
Wow. Wow.
And now I'm back to experiencing life like I was used to experiencing it prior to having the cataract.
Yeah.
So it's like the psychosocial aspect of vision, where there is a psychosocial aspect of vision.
Definitely.
And so and that quality of life. So she just opened back up. We were floored. The nurse was floored. My intern was floored. I mean, my resident was floored at the time. So, and that was just such a big learning experience for me to see the impact that it really has.
Right. And it shows that, it is so much more than just seeing it. It impacts our entire life and our quality of life. And Dr. Barnes, you had told me about your own personal experience with people having cataract surgery and how wishing they had done it sooner.
Ah, yes.
Well, one is my mother, and it took quite a while to convince her to have it done. She being a nurse, and so she knew medicine, she was aware of surgery and everything else. She worked in a pediatric ICU. So she was aware of, what surgery is like and all that kind of, but she wasn't willing to do the surgery on herself. But my mother's very independent, like a lot of seniors are.
Right.
And that about the geriatric population is that the biggest thing I think is losing your independence.
Exactly. Exactly.
Being dependent on someone, whether they have to drive me somewhere, they have to cook for me, or whatever I need to do, I need somebody else to do it for me. So I'm uncomfortable to do things now. And so that's one of the things happened with my mother, is that she now had a great granddaughter that she wanted to be around all the time.
Wow.
But she has to drive quite a distance to get to her, and then coming back at night, she's totally lost because she can't see.
Okay.
There's glare, everything. She had a cataract. And I spoke to her for a while to have it done. Even before that, she would never have it done. She would struggle her way through. And then after a while, because of the great-granddaughter, she wanted to be there. That motivation stirred up the energy, the positive, to say, let me have this surgery done.
Okay.
She's looking across her house out the street, but she has a sad look on her face. I said, like, Mom, well, why are you sad? Like, what's going on? She says, I can't believe how well I can see.
So why was she sad?
She said, I can't believe I waited this long to have the surgery done, and now I'm going to die.
Oh, wow.
I said, Mom, just get the use out of your lenses. Just don't die.
Right.
Make sure you can see, use them.
Live a long
And so
life.
she's happy. I just saw her yesterday. She said the same thing about the diner. She's like, I can't believe I can see across there and see this house so clear, that, how happy she was.
Yeah.
But it took her, some time to do it, but she did do it. She's very happy. But I'm a low vision doctor, so I see those patients that are visually impaired. The ones that had cataract surgery or had diabetes, they had surgeries done, and they don't see well even after all that's done. In low vision, working with visually impaired, legally blind, the one thing, like Dr. Carter mentioned, is still getting the best pair of glasses, giving them a refraction that they can see the best that they can.
Right.
And then we do adaptations and devices to use them, that we use to help them get the best efficiency, the best help that they can get out to perform independently. So that's my goal.
And that's one of the things that I think is so amazing with your office, and you have everything right here, the technology that has changed that can help people in so many ways. And I think people aren't aware of that technology. So the only way to find out about it is to actually go to your eye doctor and learn what's new, and not be thinking that, well, 20 years ago, there was nothing they could do and they can't do it now. So how are ways that you think we can encourage people to have their eye exams or overcome the fear of going to the doctor? I mean, fear might be holding them back, but without going to the doctor, they don't have these corrections and they don't learn about the new technology.
If they think there's could possibly be something,
Yeah, that's true.
I don't want to hear it. Because now I'm scared of what it might escalate into.
Okay.
And so that's what people's concerns are, whether it's eyes or teeth. Well, I'm not going to go to the dentist because I know that pain there. Does that mean something going to happen? Or I'm not seeing well, or I saw a spot. What does that say? And so they get a little hesitant because of that, because they're scared of the next step that might happen, or that the doctor may say you do have a problem. So they're hesitant. But the thing is, you want to catch it early before it becomes a bigger problem, and then you have to do more intervention.
Right.
That's
Something
true.
that could have been taken care of simple now is more complex. So it's always best to seek out the answers earlier.
Okay. Can we go and look at some of the technology that you were talking about and what's available to help people?
Yes,
Sure, absolutely.
They go from simple to magnified telescopes to artificial intelligence. That something called OrCam. I'll show you that too, how that works.
Okay.
So you have retinal imaging that now can look at the entire retina nice and easily without dilating the pupil, which is very good for patients, or they like not being dilated, especially if you got cataracts or glare, or just in general glare, even without a cataract. So that's nice technology. So that maybe sometimes why they don't want to come get an eye exam could be, oh, my pupil's got to be dilated. I don't like how that felt the last time. So nowadays you don't have to be dilated and still have us look at your retina. When you have glaucoma, then we are more apt to have to dilate you. But the technology now for glaucoma really is more advanced, where we can rule out glaucoma much more quickly than we could in the past. So you have technology that can now look at the optic nerve. You can take pictures of the back of the eye, and that's your optic nerve, and that's where glaucoma happens, where it damages the nerve. But not only can we nowadays look at it and say, okay, is that glaucoma based on the cup? But nowadays you can actually analyze the nerve. You're literally counting nerve fibers. And that's what something like this technology does for us, which we love having. So this instrument will say, well, how many nerve fibers do you have? Oh, you have 1 million? Do you still have 1 million? That's, you start out usually with 1 million nerve fibers. So it makes just the whole process much more easily achieved, less office visits, because you can quickly come up with a diagnosis. Nowadays too, what's really nice is there's technology where there's autorefractors. So this can really help us come up with a really good refraction, because it gives us a nice baseline what your prescription is. So back in the day, we didn't talk a lot about oil glands when we talked about dry eye. It was just, oh, how much tears you're producing. And now we know that there's more to dry eye than meets the eye on the surface. Very common condition is called meibomian gland dysfunction. So when you are talking about the tear layer, okay, you have various layers. You have the outer oil layer, you have the inner aqueous layer, and then you have the mucin layer that helps the tears stick to the eye. Well, the tear layer, the aqueous layer, is what we know most about, and that comes from this oil gland called the meibomian gland. So yeah, I'm secreting tears. When you get age, that dries up, as does everything, your skin, your hair. So it's common to have this gland decrease production. Nowadays, though, you have prescription drops that help stimulate the production out of this gland. And what's very new is you have something called Tyrvaya, which is a nasal spray into the nose for dry eye. And this gland here, right, trigeminal, it connects to the lacrimal gland that secretes tears and these oil glands. So now a person who may have a hard time putting drops in their eyes as you get older, mobility, etc., now you can just squirt in your nose a substance that can stimulate your natural tears. So all it's doing is stimulating your natural tears. It's not supplementing tears, it's stimulating your natural tears. This instrument here is where you're going to find your disease. With my slit lamp, I can magnify things, which is nice. I can use a special lens and look from the front of the eye all the way to the back of the eye, to the retina, just with this thing and my special lens that I use that allows me to see through the pupil all the way into the back of the eye, and now I'm able to highlight my retina. That's my baby there. You measure glaucoma with the tonometer probe. This is the best way to measure glaucoma, not like with the air puff. Okay, air puff is like a screening, but this is your exam. When you're older, you definitely want an exam where they're measuring your pressure with a tonometer, or there's other tonal pens that they hold and do it, but not an air puff. That's very important. That's just a screening. As you get older, a lot of times you're wearing contact lenses and people want to then stop wearing their contact lenses. One of the things that's going to make you stop wearing them is your eyes are dry. So we want to nip that in the bud, because getting you or helping you stay in your contact lenses really helps you feel good about yourself, right? So especially if you've been used to wearing them. You can get some peripheral constriction with glasses, and so contact lenses can make you feel better. Nowadays we have bifocal contact lenses. A lot of times people may not be aware that there is something called a bifocal contact lens, just like in glasses where a bifocal helps you see the distance and the near. So now you have a whole slew of contact lenses, like we have dozens of contacts now on the market that can help a whole variety of conditions, including presbyopia, that can help keep our seniors in their contact lenses longer. Like, I hope to be able to wear my contact lenses forever. That's my goal. So, and then we have for those patients who are visually impaired, and I'll let Dr. Barnes take over from there.
Well, that's when we do low vision, working with the visually impaired, legally blind. There's something that the state of New Jersey has, wonderful Commission for the Blind and Visually Impaired, and they help support those that are visually impaired with aid, to help them get certain aids like we have here to help them see. A lot of them, let's say my patients are macular degeneration, glaucoma, and diabetics, or surgical issues that happen that they don't see well anymore, retinal detachments. And so we have to optimize their vision with what they have left. And sometimes we use something that is simple as a magnifier. We have different types of magnifiers that help. And lighting is important, which Dr. Carter brought before. So most of the magnifiers will have a light with it also to light up what we're looking at. And there's all different type of magnifications that we use that are optical. And then we have magnification that is also for up close for reading. Then we also have it telescopic for see things far away. Someone will have this around them like this, and they will use this to see things at far. And there's different type of telescopic aids that we have. And there's some that are, these are optically related, and then we have some that are electronically, where we have large ones that are desk mounted, and then we have different sizes of electronic video magnifiers. So we have different magnifier things that to help them see things that are easier. Some of these are also voice. that it magnifies it and also will read it for you to give them some backup. And it can be something as simple as this, or we can go to more AI things like this OrCam here. And this has a camera in front, has a speaker on the side, and it will read for you. So some of my patients that are visually impaired, these things don't help them with, and so we go to something that will read for them. That was a demonstration one, but this is an actual one, and what happens is you press here. That will turn on to activate it. And there's one called OrCam Read that's like a stylus that you hold like a pen. But this one, you actually, there's a little magnetic on the frame here. And we can push it onto the frame like this. And then it can read for us.
OrCam My Eye, version 9 is ready.
So it just let me,
82% charged.
it told me it's ready, the battery's 82% charged, so it gives me feedback. But they have another one, OrCam Read. That one has a stylus, you hold it in your hand. That one has it so that you can do Bluetooth. So you can have your AirPods on and it will speak, only you will hear it. So that social stuff that some people are concerned about, then we have to use this one. This one, the OrCam Read, is not as complicated or advanced as the My Eye here. It can recognize faces, money, barcodes, and it lets you do it. And we wear this, let me just give you an example. I'm gonna read this here. If I want it, it can read just by touching it. I'm gonna just point to what I want to read.
From space exploration to microsurgery to modern movie making, professionals who insist on precision optics choose Zeiss. 12 binds.
So it will read. I hold like that, it will stop. Now I can also point to it, or I can activate it, tap it twice, and you can do voice commands. So you can just talk and tell it.
Volume down. A woman and a person are in front of you. 6. Low vision. 32 binds. Lenses from Zeiss. From space exploration to microsurgery to modern movie making, professional.
And to show that can be magnified as much as a person needs or less. And we try to use the least amount of magnification as possible so you get a larger field of view. And we spoke about lighting before, and so we have special lamps, these LED lamps that are portable. Some are just desktop, but to try to get good lighting, because to prevent shadows and to illuminate what we're trying to read, so you have better contrast and you better results with that. So we have different things for that. But you also can experience a lot of glare. And so some people will need special glasses and special tints that they're more comfortable with. We found out these tints for certain conditions are better. Let's say the yellow one, that improves contrast. So that's good, but some of them, it also makes things brighter. And some people might need it darker, so we get darker tones also, some ambers, some browns. So we have these solar comfort type of glasses too to help them out that are light sensitive.
Well, thank you for showing us your office and facilities. It really is an incredible space. And I want to thank all of you for joining us today, and Drs. Carter and Barnes for sharing their expertise and showing us the potential and what really can be done to help you maintain good vision as you age. Aging Insights is brought to you by our funders, supporters, and viewers like you. You can watch this and past episodes of Aging Insights on YouTube or through our website, njaaw.org, on the Aging Insights tab. And you can listen to us where you find your favorite podcasts. For an extensive list of resources for older adults, visit our website at njaaw.org/services and resources.